dovetail on what David was saying. You've reported on some use of concomitant radium and abiraterone.
Yeah, so this is an interesting fellow. This is a relatively young man who has highly aggressive disease, and he received his Sipuleucel T, and then there was kind of a delay for his next line of therapy. In my clinic, I would have almost invariably, within a fairly short period of time, started him on one of the novel hormonal lines of therapy, either abiraterone or enzalutamide. And in my experience, what typically happens is that there's, for the vast majority of patients, we see those PSA declines, but then invariably the PSA starts to come up. And some have described this as now some evidence of a biologic progression. There's, perhaps mutational events happening. And then there's a lag period, and then invariably there will be radiographic progression. And if you're following the patient close enough, and eventually more symptomatic or more symptomatology. In the study that we did, we reported it now at ASCO GU and at AUA, is we combined abiraterone and radium-223 concomitantly. And we started our investigator-initiated trial before there was even any evidence from the expanded access program. So the bottom line is that combining the abiraterone and radium-223 does not change the safety profile or the toxicity events. They're still there, what you would expect to see if giving it as monotherapy. And we've actually reported that the majority of our patients have had FACP subset decreases in their quality of life, improvement in their quality of life, lowering of their pain tolerance as well. And BPI was measured as well, and that also decreased. So it's not true for all patients, depending upon where you start them. So I'm actually more of the mindset to be more aggressive in combining the therapies together. As you know, and everyone here knows, in the Alsimca trial, the best standard of care combined radium with ketoconazole, which is an androgen biosynthesis inhibitor, and the earlier generation lutamides, bicalutamide, nalutamide, flutamide, steroids, estrogens, focal radiation. So I actually am very aggressive in combining therapy and not going step by step because, as was mentioned, I want to get in the full 6 cycles and have the ability to give chemotherapy when it's appropriate.
No, Mike, your point was well taken, is that there are these windows, and these windows seem to close pretty quickly. And I think we have to hit that window, we have to hit that opportunity. The one patient that really bothers me is the elderly 78-year-old, 80-year-old with multiple bone mets, no soft tissue disease, and he is truly asymptomatic. And to me, that he is a walking time bomb. And of course, that's not the indication to give radium-223. Didn't the European Early Access Program report on some of those patients? Or?
You mean combining it with abiraterone?
Yes.
Yes, I mean, it did seem that there was a survival benefit. I mean, those patients did seem to do better than either drug alone. So I think that's a very interesting observation. We're actually, hopefully later this year, we'll have a trial that will read out that compares Abi plus radium to Enza plus radium to radium alone as far as radiographic progression-free survival is concerned. So that may give us a little bit more information about what the role of these other agents are in combination with radium. But getting back to Dave's point, the data suggests that you really need the full 6 doses to get a survival benefit. So what I would tend to do in a patient where they develop visceral disease is treat them at that particular point with chemotherapy. If I get a really good response, then I'll finish it up with the radium after that. So that may be a way of selecting those patients who are going to do better.